I was really excited over the fact that through no planning of my own, we have a clinical pharmacist during American National American Pharmacist Month. It was like, oh, I'm so clever. Didn't even know it. So Shane Johnson is with our Kadlec Senior Clinic that's at Leslie Gage. He is the clinical pharmacist, and I thought, I don't even know what that is. What does he do there? And he's going to tell us all about that. And we're going to learn something about a little history, too. So, Shane, it's all yours.
Thank you. As a clinical pharmacist, my role is different, actually, than a lot of other clinical pharmacists as well. So I work in an ambulatory care setting in the senior clinic. Is anyone in here a patient in the senior clinic? You don't have to raise your hand if not, but it's basically we only see patients 65 and over, so it's kind of a specialty practice. It's kind of an exciting thing for me. I did an acute care residency actually, and one of the things that I really took home from my residency program was, it's really disheartening to see people constantly land in the hospital for the same sorts of things over and over again. So part of my role here is keeping people out of the hospital, preventing readmissions and that type of thing. I work with patients and their medications and try to help, sort of square away their lists for them, help them understand what their medications are for, find problems with drug interactions and duplications and omissions at times when there's a medication maybe they should be on that they're not. But I'll talk a little bit more about that as we get into this. So one of the first questions I typically get is, what is a clinical pharmacist? What do they do, and what does that mean? To really understand that, I think you kind of have to look at some of the history of pharmacy and our evolution as a pharmacy practice. I think that this cartoon is a really good description of sort of what that looked like. You've got a whale there, and the cartoon says, I can't fly yet, but if I keep flapping my fins, some of my ancestors maybe in millions of years might be able to fly. So that's sort of how this started. Pharmacists started out as sort of a dispensing role. And slowly that's progressed into a more clinical role in offering support to patients and providers as well. Perhaps one of the first examples of pharmacy practice comes from ancient Babylonia. That was, at that time, the holistic providers were practicing sort of a mix of both traditional healthcare as the physician. They were practicing the role of the pharmacist and also practicing the role of the spiritual healer. So their medical texts at that time had sort of a description of what the symptoms of disease might be. In addition to that, they had maybe a regimen of medications that they might try and compounding instructions for those medications. And then they also had sort of an invocation to the gods as well. So they were really playing sort of three roles there. In ancient China, there was an emperor by the name of Shen Nung, and his role was really sort of experimenting with different medicines and herbs and finding out what they might do to treat illnesses and that kind of thing. He actually documented about 365 different drugs and their concoctions and how you might mix them up and prepare them. Most of these things he actually tried on himself and also people that were sort of his followers to kind of get an idea of what they would do and what their medicinal properties were. A more comprehensive historical text that exists for ancient medicine was the Ebers Papyrus, and that was formulated about 500 years after this emperor was in existence and working on medicine. This is basically a compilation of quite a few different medicines. Some of those are actually things that we still use in practice, like senna for constipation. It also had things that were predecessors to current medications, like poppy that they used for sleep at that time, but obviously we use derivatives of the poppy seed now for treating pain. And so that's kind of an interesting textbook, and that was really the best known sort of pharmacological textbook in history. Then we kind of get into this differentiation from apothecary to druggist to now pharmacist. You guys have probably heard all those terms used in different references. Apothecary really was something that started to pop up in about the 8th century or so. Arabs were the first ones to really start to differentiate the practices of medicine from the practices of pharmacy. And that was really when this role of pharmacist started to take shape. That actually didn't catch on in European civilization for about 600 years after that. But Arabs were doing this for a long, long time prior to that coming to European countries. Basically what they define the apothecary as is somebody who sort of formulates, prepares, and dispenses medicines. they were also somebody who would offer sort of traditional medical advice, much like your community pharmacist does today. The druggist is a term that often people from a generation, probably about 1930 to maybe 1970 or so, typically use. Most of you guys are probably familiar with that term. Most pharmacists kind of shy away from the term druggist now. It's sort of associated with somebody who mostly dispenses or sells medications or something like that. Actually, if you look, these are two definitions I found online, a retailer of medicine and then one who sells drugs, which is pretty a broad term. I would call that a drug dealer, but apparently that's a definition for druggist as well. What I think about when I think of a druggist is probably something more like the traditional soda shop. Here on the left, this is a picture of Shaw's Pharmacy. That's in Seattle. On the right here is another soda fountain in Illinois. And that's kind of what I think about when I think of druggist. It was a great time in pharmacy. It was definitely an expanding time of pharmacy, and over time that's gotten to be much more extensive as well. The term pharmacist is something that is kind of synonymous with druggist, but really traditional pharmacists, that's really something that was originally established through apprenticeship. After World War II, they came out with these Bachelor of Pharmacy programs, and that's where they started training pharmacists. And typically that would include about 3 years of study and then also usually some apprenticeship after that. In January 1st in 1974, Washington actually became the first state to require counseling on all new medications. That sounds kind of funny now because we know that's what pharmacists do, and that's a central part of our practice. But really, Washington was the first one, and it wasn't until 1974 that became something that was required of a pharmacist. Prior to that, pharmacists really took kind of a hands-off approach, and most of what they were doing was just dispensing. And that's kind of the differentiation between the druggist and the pharmacist in my mind. Washington continued to be pretty progressive, and so in 5 years after that, they established laws that allowed pharmacists to participate in collaborative practice. So they were the first ones to allow administration, monitoring, and or prescribing of drugs by a pharmacist as part of our profession. This is kind of a graph that shows how early Washington really was in that progression. You see Washington clear over here on the left in 1979. It wasn't until 1996 that other states really started to catch on, and pharmacists actually still don't have an inclusive role of prescribing in some states currently. So the modern pharmaceutical care, there was a paper that was published in 1990 that really sort of defined what pharmaceutical care is today, and that was really the big shift. It asked for us to mature as a profession and accept our responsibility to reduce problems with drug-related morbidity and mortality. It asked for us to not simply dispense the correct drug, but to also make sure that we were forming cooperative relationships with other professionals and to ensure the safe and effective drug use in our patients. So asked for a much more far-reaching role. A Doctor of Pharmacy, which is the degree that I hold, and anybody that's graduated from a pharmacy school in the last 10 years or so probably holds. That was something that began in 1950 in the University of Southern California. It didn't really catch on, obviously, until this term of modern pharmaceutical care came about in 1990, and pretty soon all these other pharmacy schools says, hey, we need to get on top of this and start converting our programs from a bachelor program to a doctorate program. So now we finally get to what is a clinical pharmacist. This is what you guys have all been waiting for, is to find out what I actually do and not just stand in front and give a history lesson. So basically what we do is we assess drug problems and health problems in a holistic view. We want to know, are the patients on medications that meet their needs, their goals of care? We evaluate the medication appropriateness. Are they on the right medicines, and are they effective medicines for the patient? We recognize untreated health problems, so that's what I talked about with therapeutic omissions. When a patient's not on a medication like maybe an ACE inhibitor, if they're a diabetic patient, that's something that we try to tackle and play a strong role in persuading both the patient and the physician that they need to be on those medications. We consult with the patient's physicians and help sort of direct therapy to meet the goals of care. We advise patients about their medications and provide education when necessary, and we refer patients to physicians and other healthcare providers as necessary. So now that we've kind of defined clinical pharmacy, more of what I do is medication therapy management, and I'll talk about what that is. Is anyone familiar with the term medication therapy management at all? Have you guys gotten these letters in the mail in the past probably 6 months that are advising you about problems with your medications or things that you should follow up with your providers? Has anyone seen those from their Part D sponsors? So that's really what medication therapy management is. If you went to Google and typed in medication therapy management, at some point, probably a couple links down the page, you'd see something about sort of this new federal regulation. This regulation, in all of the text down here below, basically what it says is any Part D sponsor, the people that administer the Part D plans for your prescription drugs, they have to provide medication therapy management. And the rest of this text sort of spells out what that means as far as medication therapy management. And anyone can really do medication therapy management, but really, you know, my argument and most people's acceptance would be that pharmacists can do that better, more efficiently, and at a more successful rate than other healthcare providers. These are the letters that I'm talking about. You guys have probably seen something like that that's come through from your Part D plans. They'll look exactly like this right down to the font, because that's a federal regulation actually, is they have to be in this exact format. They have to have that text size, that font. They have to be in this sort of table format over here. But basically that's kind of what I do, but I provide a much more personalized approach to that. You know, if you guys got these letters in the mail, 9 times out of 10 you're probably going to throw them away because they don't mean a whole lot to you, and you haven't participated probably a lot in that discussion with a pharmacist or other healthcare provider. So what I do is I provide some personal reference to that and help you guys understand what those problems that these letters that they send you, what those really mean. And I can also identify maybe other problems that aren't included in those letters. Some more background on what medication therapy management really is supposed to do. Adverse drug events. So that's basically anything that a medication does to you, or harm that it causes, or effect that it causes that wasn't intended as part of the drug therapy. There were 1.5 million preventable adverse drug effects in the last year, and 700,000 emergency department visits that led to 120,000 hospitalizations, and about 100,000 total deaths from adverse drug events last year. So there's a lot of problems with drugs out there that cause people to be admitted, cause them potentially ill consequence, either in the ambulatory setting or in the hospitalized setting, kind of depending on where that event takes place. Older adults, so 65 and older, most of the people in the room, you're twice as likely to have to go to the emergency room for one of these types of events, and you're 7 times as likely to be hospitalized. And we all know being hospitalized is more than just getting better. Sometimes more bad things can happen in the hospital. That's where other infections might hang out, and you can possibly acquire an infection in the hospital system. Another thing that I'll talk about later on is sort of that transition of care can be very sloppy for patients and cause a lot of problems as well. Kind of a depiction in a graph of what this looks like. So this was a study that was done on patients that reported an adverse drug event in the ambulatory setting. You can see from 25 to 44, there was only 1.3 per 10,000 patients. And this, again, is just ambulatory setting. For 65 and older, that risk basically tripled. So you're at a 3 times higher risk for adverse drug events than what somebody my age and up to about 44 years old would be at. So it's really important that you kind of take hold of this and recognize that there could be problems with your medications that potentially a physician, a nurse, or even your local pharmacy may not catch, and it takes some time to really look into your medications and find out what problems might arise. Some other factors that were associated with adverse drug events. This is kind of interesting. Who was paying for your care actually influenced that a little bit in this particular study. Self-pay patients or charity patients were actually at a 0.26, so they had a 75% lower chance of having an adverse drug event than somebody that was on a private pay insurance company. Probably what that relates to is the number of medications they're on. As you can imagine, people that are paying out of pocket for everything or having to go find charity programs to pay for their medications, they're usually on fewer medications in general, and that contributes probably significantly to this number. The number of medications, this is probably the biggest one. You don't have to raise your hand, but think about how many medications you're on currently. If you're on 6 or more medications, your risk is quite a bit higher than somebody that's on 1 to 3 medications, and your risk of somebody that's on no medications is almost 4 times as high. So that's a huge contributor. Drugs interact with each other. A lot of the interactions we know quite a bit about prescription drugs. Yes, question? Yeah, it absolutely. The question was if you're taking more than one medication for the same indication, for the same reason, does that count as more than one medication? And absolutely, because what happens there is you might be on 3 different medications, hopefully of different pharmaceutical classes, and each one of those different classes has different interactions with other medications. So definitely that would count as multiple medications. And also, a lot of people forget to count their over-the-counter medications. So if you take Tylenol, or if you take, I might talk about drug interactions later on, but if you take like ibuprofen or naproxen, those medications do interact with prescription medications, and so those are things that would also count into this number. So definitely a big problem. Comorbidities, other studies have shown that having multiple chronic diseases, that contributes to this problem as well. This particular study didn't find much of a contribution, but as you can imagine, if you're diabetic, you have high blood pressure, you have high cholesterol, you have maybe Parkinson's disease, that's going to add more medications to your medication regimen than if you just had diabetes alone. So that's definitely a factor in this as well. A little more background on this. Common adverse drug events that can lead to hospital admission. These are the most common things that happen with patients that put them in the hospital due to drug problems. Toxic drug levels or abnormal lab values. That's most frequently why you land in the hospital. If you have poor monitoring of your medication, say you're on Coumadin, or maybe you're on a different medication that requires close monitoring, that could be a reason. Inappropriate dosing, if you have poor kidney function and your medication starts to accumulate in your body because your kidneys aren't able to handle that dose, that can lead to a hospitalization. If a patient's not compliant, if they don't take their medication for 3 days and then they say, I'm going to triple up on the dose on day 3 because I forgot the last 2 days, that can contribute to problems. And drug-to-drug interactions, as you can all imagine. Every patient I see, I had one patient this morning that didn't have any interactions in their profile. I had a patient about 3 weeks ago that didn't have any interactions in their profile. Every other patient since I started in June had at least one drug interaction. And those are always important to pay attention to. Some of those are significant, some of them really aren't. It just really depends on what the interaction is. Overall, about 62% of adverse drug events are potentially avoidable. And as I said before, pharmacists have been identified in most studies that they're probably the most equipped to identify these adverse drug events and stop them before they become a problem. Who benefits in this process of medication therapy management? There's been a lot of studies to look at who the people are that we should focus on with medication therapy management. If you're going in a transition of care, if you were living at home and you had something come up, maybe you had pneumonia or something like that and got hospitalized. That's called a transition of care, where you change from one healthcare setting to another healthcare setting. And that's a big problem because what happens is typically medications may get changed while you're in the hospital. If you don't have a very good medication list before you went into the hospital, they may not know what to put you on once you're hospitalized. And then when you come out of the hospital, sometimes when you're in the hospital, they'll change you on a formulary to something that the hospital has on formulary. When you leave the hospital, sometimes that's not well communicated, sort of what medication you should be continuing on and which one you should stop as you go back to home. A change in medication regimens, like I just talked about with transition to care, or any other change in medication that comes up. If you've got multiple chronic conditions, I talked about that already, multiple medications. If you have a history of non-adherence, some patients are chronically just really bad with their medications. One of the best things we can do for them is educate them on the resources that are available, whether it's a pill dispenser or bubble packing or whatever it might be, to help them sort of understand how to take their medication. Limited health literacy. Most people are limited health literacy, and if I sat down in, for instance, maybe an oncology lecture right now, I would have limited health literacy. So everyone has some degree of that, and so making sure that we communicate well with our patients is really, really important. And then also, if you just want to reduce healthcare costs, medication therapy management can help. I get a lot of patients on Crestor. They've never been on another statin before. They've never trialed any other statin. That would be an instance where Crestor is probably not the cheapest and most effective drug for them to take. Other times, Crestor is a really good drug. If you've had intolerance to other statins in the past, it's a really good option to alleviate some of those problems. So all in all, basically everyone benefits from medication therapy management. Everyone can find some utilization in this, whether it's just sitting down and talking with someone and knowing that there's someone out there that cares about your medications might be the only benefit you get out of it. So how do we get there? We know medication therapy management is good. We know that clinical pharmacists are helpful in preventing these. You guys know what a clinical pharmacist is now. So sort of how does that process look is the next question that comes up. The Joint Commission of Pharmacy Practice is actually the first ones that sort of spelled out this process very well for pharmacists. It's sort of a standard approach to providing medication therapy management in the community setting. And it emphasizes really a team approach and pushes pharmacists to move outside of the box of being a medication distribution service and really being involved clinically in the patient's care. This is sort of what their layout looks like. You guys may not be able to read that all that well from where you're sitting. Basically, there's 5 steps. The first step is to collect the information. Collecting the information can be anything from checking for drug allergies, asking the patient about their allergy history, finding out what their social history is, if they have a history of smoking, alcohol use. Those, again, can interact with medications, so we have to know about that. Putting together a medication list, figuring out what the patient's actually taking at home. So when I sit down with a patient, I like them to bring in one of 2 things. Either their medications in the bottle, and I suggest they just clean out their entire medication cabinet and bring in everything that they have at home, because I'd like to know about all those things that they have access to. That's really, really important. If they're in long-term care and the long-term care facility is taking care of their medications for them, that's like a home run for me. That's really, really easy for me, because what I get when they're in a long-term care facility is I get a MAR, a medication administration record. I can see exactly what the patient's getting. I can see when they're giving the medication, and I can see the doses. Everything there is spelled out, and if it's not spelled out, then the long-term care facility has a real problem, usually. So that's something that I like to see for sure if they're in long-term care. The other thing that some people bring in with them is their medication list. Some people do a really, really good job of updating their home medication list. Other people, it's kind of wavery, but usually they can fill me in on the blanks, things that aren't included on that list. One of the things that I try to educate patients about more and more, they constantly tell me, well, your medication list in your computer should be up to date. That should show everything that you're on. That's not always the case. Usually a medical assistant who do wonderful, wonderful work in our clinic and are really great support staff for our providers. They do a really good job of their process. What they're not trained in is medication therapy, really. For me to look at a medication list is much different than somebody that's trained in as a medical assistant. So those lists are frequently out of date, frequently have problems, and you can never really rely on the computer until you have somebody that's really sat down with you. In my instance, I sit down with a patient for 45 minutes, and when they leave my office, that medication list is perfect, so at least to the best of my ability. The assessment portion is really me looking at drug interactions, whether or not they're on the right medications for the right disease states. That's looking at duplications, omissions of therapy. Like I said, if they're diabetic and they're not on an ACE inhibitor and they have high blood pressure, I'm going to be asking why. They should really probably be on an ACE inhibitor or a medication like an ACE inhibitor. The plan, that's when I sort of develop into what you should do going forward. Sometimes I make medication adjustments while they're there in the clinic. That may be an adjustment based on kidney function or addition of a medication that they should be on. I do have collaborative practice with the physicians in my clinic that I can make those changes if necessary. I can also provide you with recommendations on following up. If your cardiologist manages your blood pressure medications or an antiarrhythmic or something like that and I see a problem with it, I'll give you a note. I'll usually send a letter or an electronic note to your cardiologist and let them sort of progress with the plan, because I'm not going to get in the way of what your cardiologist is doing, certainly. But if I see a potential problem, I'm definitely going to try and let them know about it and let you know that I see a potential problem. Implementation, that's again just following through with those recommendations and make sure that they actually get acted on, or at least somebody acknowledges why these problems exist. Follow-up, usually if I make any change or even if I don't make a change, I'll typically try and contact my patient within about a week. That's just my normal standard of practice. We also follow up with people in the clinic, or I send them to see their physician within a couple of weeks. So kind of reiterating this concept, this is basically my terminology for each one of these steps. So as far as collecting, that's the medication therapy review. I talked pretty extensively about that. The assessment, that's establishing a personal medication record. I send every patient home with that complete medication list. I'll spell out, what the instructions are and also what the indication is. A lot of people get on medications and they don't really know what they're on them for. So that's the other part of my job, is educating everyone and making sure that they understand that. The planning and implementation, that's the medication action plan, and then I usually recommend a follow-up or referral to somebody else. And then documenting, if you guys aren't using my K-chart and you're a Kadlec provider, I really suggest it. I know not everyone has access to a computer, but it's really nice to go in and be able to see actually what our computer shows us in the clinic as well. That's a very good current reference that you guys can use at home. So the other question that I get, a lot of people don't know what medication. Yes, a question over here. What liability is associated with a provider of MTM? So as far as the pharmacist as a provider?
Carry liability insurance?
I do, absolutely, yeah. Any pharmacist probably should carry some liability insurance regardless of where they practice. I do carry liability insurance myself. Part of my liability is within my clinic, and then obviously the providers that I have collaborative practice with take on some liability as well. So there's definitely a shared liability, and part of that, in part of that sharing of liability, a lot of my job is sort of building relationships with the providers I work with and helping them understand sort of what my expertise is and what I can help out with, and also the things that I can't help out with, because there's certainly, like I mentioned before, oncology is not something that I'm particularly familiar with. I wouldn't be comfortable recommending any oncology medication for somebody. So there are things that I shy away from, certainly. Most of what I do is chronic disease management. That's what I like to do, and that's what I like to be involved with for the most part. So does that answer the question?
Yeah.
Okay. So what are patients saying? How many people before this talk started knew what a clinical pharmacist was? So already knew what a clinical pharmacist was. So there's probably a couple in the room, maybe. How many of you knew what medication therapy management was? So not knowing a lot about what medication therapy management is or what clinical pharmacist is, when we try to call and schedule patients, we have a real hard time getting them in the clinic. Before receiving medication therapy management services, 92% of patients weren't familiar with MTM. That was about the numbers we had here. We had a couple hands that went up. 70% say they don't need MTM services. That would probably be what we'd see here if we had asked you guys beforehand. And 66% say they wouldn't pay for MTM services. Good news is, right now, basically the way I bill, if your deductible's already paid, all that just comes out of your Medicare anyway. Your Medicare will pay for some of the services that I do. There's also some legislation in the books right now that would further extend the ability of pharmacists to capture charges based on medication therapy management services and chronic disease management. Currently, that's in the House of Representatives, and they're working on trying to push that through legislation. So that's hopefully up and coming, and will definitely support my practice a little bit more. After receiving MTM services, perceptions drastically change. People always leave my office with a positive outcome. They really enjoyed the service. They got a lot out of it. At the very least, like I said, they felt it was very educational. And usually after experiencing the service firsthand, they find it, very, very beneficial, and they would definitely come back and do it again. I get patients that I've already seen 4 times, up to 4 times, in just the last, couple of months or 4 months or so. It's pretty remarkable how quickly people really catch on to this and get a lot of value. Some of the things that people generally say is that it's a very collaborative approach. The pharmacist is another member of the team. We provide support to the physicians and to the patients and make sure that they're safe and that the medications are effective for them. One of the big parts of my role is my physicians really sort of levied to have me there. They want to have me in the clinic because they recognize how many medications their patients are on. I've had patients from anywhere from 3 medications all the way up to 43. And it's pretty remarkable how many medications some people take and don't sometimes even know what they're taking all those for. We're a good supporter and an advocate and sometimes a confidant, somebody you can just, tell your stories to and they'll listen. That's really what pharmacists nowadays are trained in doing. The MTM pharmacist, instead of treating the illness, actually helps you to get to wellness is really what we're focused in. And it feels like there's somebody working with me instead of against me. Oftentimes people feel like they go see their physician tells them all the things that they're doing wrong. which is a good thing. You know, they're trying to steer behavior in a positive way. Pharmacists are really good at just sort of working with the patient and talking with them about their medications and helping them devise a strategy that works for them. That's really kind of what my focus is. It's very educational. We talked about that a couple of times now. Improved access to care is something I haven't mentioned. People really respect the fact that they can call the clinic, they can talk to me. Any time of day I'll pick up the phone, and if not, I'll call you right back. You'll talk to me. I don't have medical assistants, so you don't have to worry about talking to a medical assistant instead of the doctor. I'm the one that usually returns all the phone calls that come in for me. And getting the opportunity to spend 45 minutes with a healthcare provider is very rare nowadays. I'm sure you guys are accustomed to going in and seeing a physician and maybe spending 10 minutes, 15 minutes in the room with them. If you don't see a geriatric physician, you're probably spending maybe even less time than that. Most internal medicine doctors are very, very busy, and they don't have the amount of time, although they'd like to spend it with their patients. They have to go on and see the next patient. That's a big part of what I do also, is just providing that access. Financial incentive, we might be able to save you money. We can certainly save somebody money in the long run if we can keep you out of the hospital and keep you from being readmitted. That's going to save you money, it's going to save the health plan money, and it's going to save the system money in general. Specialty service, we really have an emphasis on medications. A lot of times people come in and they want to talk to me about a lot of other problems that they're having, and all I can do is just listen and work with them and try to redirect sometimes, because really what I'm interested in is the medications. I can't diagnose things, and so when people tell me about symptoms of maybe a possible disease that they're having, it may not be something that I'm particularly astute in being able to help out with. Coordination of care, so we look at all the medications very thoroughly. I like to have doses in every medication. If somebody tells me they take calcium twice a day, I'm not just going to put in calcium twice a day. I want to know the dose that they're taking, because that's important. A lot of people take too much calcium or too little calcium, so that's really important to make sure that we get that dialed in appropriately for them. And so where do you go from here? What can you do with the information that I provided you with today? Hopefully you'll go home and create a list of your medications if you don't already have one. That's really important for your own knowledge and also the knowledge of providers that you go see. They should be keeping an up-to-date list, but if you go on vacation out of town somewhere, and for some reason, hopefully not, but you might get admitted to a hospital for some reason, hopefully you have a list that you can provide the admitting physician with to tell them which medications you actually take. Make sure you follow directions from your physician, your primary care provider, and any other specialists that you see. Ask questions of both your doctor and your pharmacist. Make sure that you're well-knowledged in all the medications you take and why you're taking them, and any specialty instructions with those medications. Keep up to date with your blood work. Sometimes there's medications we monitor based on certain levels. If you're on a cholesterol medication, well, it's probably a good idea that we know what your cholesterol level is so that we can continue to treat that appropriately. If you're on thyroid, just about every patient nowadays is on thyroid medications. We need to make sure we're monitoring that. And also make sure you ask your doctor or your pharmacist about any of the over-the-counter medications and supplements. Especially, I would ask before you start taking them. Make sure that there's not a problem with an interaction. Make sure that your doctor agrees with why you're taking it. A lot of over-the-counter things are fairly benign and they don't cause a lot of problems. One of the big things I run into is patients get on 10 or 15 different over-the-counter things and they say, well, if they're not causing any problems, why do you care if I continue to take them? And usually the approach that I take is what kind of data is behind them, what supports their use in practice. And if there's no good data behind the supplement that you're taking, you probably shouldn't be taking it because you're probably wasting your money. I think that that's really something that people need to consider as well. Find somebody that's an expert in medicine and have them look up any of the natural medicines that you're considering. I'm not against natural medicine for sure. I think there's some really wonderful over-the-counter things that are out there, but making sure that they're actually wonderful and not just somebody telling you that they're wonderful is kind of the key. Here's a sample medication list, and what this basically has here along the top, the name of the medication. It would be good to have the generic and the brand so that you're familiar with both. A lot of people only know the brand name, and that's fine. If you know one of the names, that's a lot better than knowing none of the names, right? But it's really good to know both. That way when people talk to you about either name interchangeably, I think it's a real pain. I wish we could get away from the system of having brands and generics, but for the most part, it's probably good to know both. The dosages, you should have all the dosages listed of your medications. the actual dose that you take, not the dose of the tablet probably. A lot of people, they have maybe a co-reg or something like that they cut in half, and they take half of a tablet twice a day, and they don't take a full tablet. So it's important to know what dose you're actually taking. The frequency, whether it's once daily, twice daily, if it's in the morning or at night, that's useful knowledge to have. Is it as needed? If you take Zantac, but you only take it once a month, it's still important to include in the list because it still could have problems. There still could be, the dose, for instance, maybe is too high, or maybe it interacts with another drug you're on, or maybe it causes some side effects that you have. We still want to know about it, but we want to know also that you don't take it every day. If you're complaining of a particular side effect, I can kind of eliminate Zantac and say, well, they're not taking that every day, so that's probably not what's contributing to the side effect that you're experiencing. Condition, you should always know what every medication you take is for, and if you don't know, you should make sure you ask your doctor or ask your pharmacist. Which physician prescribed it is good information. That way you know who sort of manages that medication. If it's over the counter, you should write that down too. And then finally, notes. I think a lot of people forget to take notes on their medications. Is there something that I should watch so that I know my medication's working? Maybe it's your blood pressure. For most people in the room, your blood pressure should definitely be less than 150/90, based on if you have kidney disease or if you have diabetes. Your blood pressure goal is probably lower than that, maybe 140/90 or 130/80, depending on what your prescriber has set for you. You should write that down and make a note of what your goal is so that you know when you check your blood pressure at home if that's good or not. I have a lot of people that come into the clinic and they tell me their blood pressure is consistently good at home, but they don't define good and they don't really know what the definition of good is, but their blood pressure in the clinic's like 180/100, and that's probably not good long term. So it's good to know that kind of thing. If there's a lab value you should watch, like if you're on allopurinol, we should know what your uric acid level is fairly routinely. And if you're not meeting your goal, you're at higher risk for symptoms of gout. And it's good for you guys to know when you get your lab work at home, what numbers are important to me to watch and what things should I be alarmed about. And ask questions. So what kind of questions should you always ask your pharmacist? As far as questions, you should always ask the pharmacist when you're picking up a new medication. Probably not a bad idea to ask your prescriber when you get the prescription originally. When and how should I take this drug? The prescriber is probably going to refer you to the pharmacist for that. What is the purpose of the medication? Both parties would be able to tell you the answer to that question. What should I do if I miss a dose? For most medications, the sort of generic answer is if you miss a dose and it's still closer in time to the dose that you missed, go ahead and take it. If it's closer to the time of the next dose, just skip it and take the next dose. That's not true for all drugs, but that's kind of a generic answer to some drugs. Will this drug interact with other medications, vitamins, supplements? Is a generic or a lower cost brand name medication available? With Part D, the way Part D works now, anytime you guys are having to pay, out of pocket $50 a month probably on one medication or $100 total on all your medications, you should always ask, is there a cheaper option? Depending on the agent, usually there's a cheaper alternative. A lot of times what happens is these formularies get set by the Part D company, and between different Part D plans, those formularies aren't all the same. One formulary may have a particular ACE inhibitor on formulary. Most of them will have, say, lisinopril. Your prescription may not be lisinopril, and they're going to charge you more money because of that. So you should always ask, is there a cheaper alternative? That information is really hard to find out. I've come to notice since performing my job at the clinic, it's very hard to find the actual formulary, but usually with a little bit of work you can figure out what a cheaper alternative might be. What side effects, reactions, or warning signs should I watch for? Obviously you want to know what harmful effects can this medication have. When will I know to call the doctor or call the pharmacist and let them know that I'm not tolerating this drug very well? And finally, how can I monitor effectiveness? This actually wasn't on this particular document, but I think everyone should know, how am I going to know this medication's working for me? And that's actually part of a different set of laws called Over 90. Any patient on Medicare or Medicaid should be told how they're going to monitor for effectiveness. Yeah. The question there was, or the comment was that she was in Anchorage and had a prescription filled and basically accidentally took double the dosage of what you normally would have taken. And started to see the effects of that within a couple of hours of after she took it. It's as simple as really picking up the phone and calling a pharmacist. Any pharmacist that's trained, and hopefully all pharmacists are trained, or they wouldn't be practicing, but they can look up the medication and figure out, what should this patient do if they took too much, if they took too little, what drugs interact. Every pharmacist that's practicing has the ability to do that. Even if it's not your own pharmacy, if you can't get a hold of your own pharmacy, go to whatever local pharmacy you can find and they can help you out. And they're not going to turn you away ever. So, okay. So that's really sort of the end of the main part of my talk. So I'll take questions now. I've got a few drug interactions if we have extra time. I can talk about some common drug interactions that I made slides for, but this is really sort of the end of the main part of the talk. Yes? So the question is, as part of my counseling and working with patients and their medications, do I go through how their medications affect exercise or what their benefits are of exercise? For instance, changing your exercise patterns for one, that may affect a drug level. If you become more dehydrated, for instance, your medications are going to be more concentrated. Some medications that doesn't make much of a difference, other ones it could. So that would be one good thing to know about. That's something that I would typically talk to them about, is their exercise patterns. The other thing is if you're on a beta blocker, for instance, that's really going to affect your body's ability to compensate for increased activity. A beta blocker sort of knocks down the ability of your heart to receive impulses that tell it to speed up. So people that are starting an exercise program, if they're on a beta blocker, or if they've been on an exercise program and they start a beta blocker, they're going to notice a big difference in how their body sort of handles that and how fatigued they get and how much energy they're able to exert as part of that. So that's definitely part of usual counseling that I do. Also, a lot of times I'll work with patients on diet and exercise, and even though that's not traditional medicine, that's not a medical or not a prescription medication that I'm dealing with, it's still part of what I do, and I try to help people out with lifestyle changes more than medicine. I'd prefer that we could get you off of some of your medicines if we can increase physical activity and improve diet. Yeah, so the question is, can sort of increased physical activity or working out really hard, can that affect your lab values? It definitely could. The biggest thing probably to do, and remember before you go in and get your labs drawn, is you want to sort of be doing what you typically do. If you typically work out pretty hard, sure, continue to do that. If running 5 miles in the morning is something you do every day, you want to do that probably on the morning that you get your lab work drawn, as long as you're not fasting and you're, low blood sugar and that kind of thing. But you want to have your typical routine leading up to the lab. It's probably not a real good idea to go out, the day before your lab and work really, really hard, thinking that that's going to improve maybe your cholesterol or something like that. It probably is not going to improve your cholesterol, but what it could do is it could dehydrate you a little bit, and that's going to make things like your kidney function look worse. It's going to make your drug levels look higher, and it's going to cause definitely some inconsistencies there. So you want to be consistent in your days leading up to your lab work. The question was taking Azilect, wondering about tyrosine-containing foods, and that's something that can come up once in a while. There's not many medications that people take that interact with tyrosine-containing foods, but there are a few. But yeah, there's definitely other medications to watch out for. For instance, I talked about levothyroxine earlier, so I'll use that example again since it's fresh in my brain. Most of you guys are aware that you should probably take your levothyroxine on an empty stomach. The reason for that is levothyroxine, for instance, binds to multivalent cations. So what that is things like calcium, magnesium, iron, those types of things can bind to that levothyroxine, and they stop it from being absorbed from the stomach and getting into the bloodstream. So that's why they typically recommend taking it on an empty stomach. It also helps with good consistency. Because those dosages are very, very small, you've probably noticed they're in micrograms for those of you that take it. You want to be pretty consistent in how much of that gets absorbed, and the best way to do that is to take it the same way every day. As diets change, people eat different things for breakfast every single day. It's not a real good idea to take those things that have trouble getting absorbed. Taking them with food is going to change how much gets absorbed on a day-to-day basis. So that being said, there's lots of people that take levothyroxine with food, and they get pretty good lab values, and that's lucky for them, but for the general population, that's not a real good idea. So the question was about crushing medications in general. In general, most medications can be crushed, but not all medications. Certainly if they're in a capsule, you should always verify that you can open the capsule. There's certain medications you shouldn't open the capsule. There's some you can. For instance, a lot of people are on PPIs now, like omeprazole or Prilosec. Those capsules can be opened, but they should be mixed with like applesauce. So sometimes there's specific things you should do even if you do open the capsule or crush the tablet. Other medications, particularly anytime you have an extended release medication, if it says ER, XR, CR, all those types of medications probably shouldn't be crushed. Now some of them, again, there's ones that cross over on the other side of the line and they're okay to crush. So you should always ask a pharmacist about if it's okay to crush. And usually that information, there's documents out there that specifically explain medications that shouldn't be crushed. You can look up package inserts and it'll tell you if it's okay. If you have a package insert at home, you could look at it yourself. But again, you may not know where exactly in that 10,000 word text that is folded up into the size of a quarter and where to unfold and look on it. So it's usually best to ask a pharmacist whether you should crush your medications or not. Yes. So the question is, when you watch these TV programs on TV and there's these advertisements for Lunesta is my favorite one. It shows a little butterfly flying over the top, but there's usually a big long list of side effects. Now the drug company is really sort of obligated to make you aware of all the potential side effects. The way those side effects get reported is they do a clinical trial, and over the course of the clinical trial, whether it's 6 months or a year or 3 years or 5 years, anytime somebody has any weird feeling, I woke up this morning tired, for instance, and everyone wakes up in the morning tired pretty much. And so if I feel that way and if I reported that to the drug investigator, that goes on the package insert. The rate at which that gets reported becomes a bigger part of that. So if I woke up tired and everybody in the room woke up tired while they're on that medication, now all of a sudden the rate of that adverse effect becomes maybe 90% or higher. That's an extreme example. No medication is going to cause any adverse effect probably at that rate. But the other thing to think about is comorbidities. What other things are wrong with patients that typically take a medication? For instance, a lot of medications that we treat Alzheimer's with. One of the things that pops up on most of those is that they cause some agitation. But one of the problems with dementia is it can cause agitation. So if most patients that take a medication are going to have a particular characteristic, that's going to make it on the package insert as well. The best thing, again, is to talk to a pharmacist or your physician and ask, are these things I should be concerned about? The risk of, maybe cancer is probably very, very, very low. And with most things in medicine, it's really weighing out the, goods and the bads. Everything that you take is going to have some negative consequence. But then again, you have to look at what you're taking it for. Is the consequence of not taking it worse than the consequence of taking the medication? For some, designer medications that are sort of not really treating it something that's going to make your life shorter or make it particularly worse, cosmetic type medications, those things, if it's causing you more harm than good, obviously the obvious answer is to stop. We talked about beta blockers earlier, for instance, and beta blockers, like I said, it might decrease your capacity to exercise, but it may also improve your outcomes of heart failure significantly, and that's going to be more important than your ability to exercise. So advertisements on TV for prescriptions, in my opinion, I think that they probably shouldn't be advertised on TV for the most part, but then again, if the problem with manufacturing of pharmaceuticals is it's a very expensive process. I think most medications, by the time they make it to the market, the company has extended probably in the $1 billion to maybe more than that dollar range. So in order to recuperate what they've spent on the drug, they need people to start taking it, and they need them to start taking it right now because they only have a limited time before that patent expires. Medications that are treating, very rare diseases, they'll sometimes get expedited through the FDA process. Medications that are treating problems that we already have other medications to treat, they don't get any special exemption, even though their medication might be better than the alternative. For instance, maybe Crestor produces less muscle pain, than Simvastatin. That's pretty well studied and pretty common. But we already had other statins on the market, so Crestor didn't really get any advantage there in going through the FDA approval process, and it's tough for them to make their money back. A lot of medications, they're lucky to break even, and some make a lot of money. Some don't make any money at all. One of the big problems nowadays is antibiotics. We're not developing very many antibiotics at all, and there's huge money available actually now the government's putting forth, saying this is an incentive for drug companies to come up with some new antibiotics, because what we have, there's a lot of resistance developing to those, and so now there's additional incentives to manufacturing an antibiotic, because those don't typically make a lot of money. So the question was about off-label prescribing and what my thoughts are on that. I think that there's certainly some really, really good off-label indications for some medications. Again, for me, it doesn't come down to what the indication is that's been studied. It's what the evidence is behind the indication. Getting the drug on the market for one indication, like I said, costs a lot of money. What they have to do to get a brand new drug on the market is a new drug application, and that's a really extensive process. If they're putting an additional indication, they get to do an abbreviated new drug application. So it's like a shortened version of that, but it still costs quite a bit of money. And so sometimes that money is just not there. They can't afford it, or no company owns a patent on the medication anymore. And who's going to study a drug that they can't market exclusively for themselves? No one's going to study. Yeah, that's
but that's kind of interesting.
Yeah,
when you think about it.
And what a lot of people don't actually know, or I didn't even know until probably a year ago about this time. Most chemotherapy agents actually are used off-label. They're usually only studied for one particular type of cancer, and oftentimes the national guidelines for oncology, they actually recommend that first-line agents are things that don't have an indication to treat that disease. So really that comes out of studying that's done outside of the drug market world. That comes from studying that's done in academia and that kind of thing, that they've found that these drugs are more effective than the alternative, even though it doesn't have an actual indication to treat that specific cancer. So that's pretty common. I had to think right behind you actually was. So when I check interactions, I can see most interactions, at just looking at a page of drugs, but at least the most common ones. But I usually type everything into a drug interaction checker anyway. And I'll tell you, every time I type drugs into an interaction checker, I don't put on the multivitamin because it interacts with everything just about. But most of that's because it like I was talking about the levothyroxine, it sort of decreases absorption a little bit. But yeah, I'd still call it a drug. I mean, it still has chemical properties in it. It has things in it that you should be aware of. You shouldn't take your multivitamin with levothyroxine, for instance. So there's one potential thing that you might get out of making sure that someone knows you take a multivitamin. Also, talking with your primary care doctor and seeing if you need to be on a multivitamin. If you eat a pretty balanced diet and you include a lot of fruits and vegetables, most likely you may not need a multivitamin. There may be certain vitamins that you probably still should supplement. Most people around here probably should be on vitamin D. But then again, it really depends on the person and what their diet is and what their other activities are. So I had a couple questions. Grapefruit. So speaking of statins, grapefruit juice. That was actually one of my slides. So grapefruit juice does have an interaction with some statins. A lot of times you get people tell you not to take grapefruit juice or drink grapefruit juice with your medications. You've probably had that happen a few times in the past. Grapefruit juice, what it does is it inhibits an enzyme in your body that metabolizes certain drugs. Those drugs include statins for one, and also calcium channel blockers, as well as a lot of other drugs out there. Calcium channel blockers are medications for blood pressure. Grapefruit juice, when it inhibits that enzyme, those drugs can accumulate. They can become more toxic if they have a toxic characteristic to them. For instance, statins can be toxic to your muscles, and eventually can be toxic to your kidneys as well. So grapefruit juice can cause a little bit of a problem. Particularly, it causes problems with like simvastatin, maybe a little bit of a problem with atorvastatin and a couple other statins. The statins down here at the bottom are actually fairly safe with grapefruit juice. They don't interact. Pravastatin or Pravachol, rosuvastatin, that's Crestor, and then fluvastatin. I don't know the brand name of that one off the top of my head, but sorry. And those are 3 statins that are safe with grapefruit juice. In addition to that, grapefruit juice with statins, you actually have to drink quite a bit. Up to 1 liter a day is really what they've studied and found problems with. If you drink an 8-ounce glass of grapefruit juice a day with most drugs, I'm not making a blanket statement there, but with most drugs, including statins, an 8-ounce glass of grapefruit juice once a week is not going to hurt anybody, but definitely something to be aware of. It kind of depends on the medication. A lot of pills can be taken together. Sometimes that becomes a problem because people just can't stomach that many pills all at once. So spreading them out is not a bad idea. If you're on 2 blood pressure medications, probably not a bad idea to take 1 in the morning and 1 at night. If you're on 3 or more blood pressure medications, you should definitely be taking at least 1 of them at night and then the other 2 in the morning. It really just kind of depends on the medications. Most of them, there's 2 types of interactions really. There's I've got a slide on that too actually. There's pharmacokinetic and pharmacodynamic. I'm not going to go completely into this slide, but when medications sort of block the absorption of another medication, that's a pharmacokinetic interaction. Pharmacodynamic is sort of what the drug does to your body. So if you're on multiple medications that have sort of the same mechanism of action, or if they cause the same types of side effects, that's a different type of reaction. So absorption interactions are fairly rare, but they do happen. Just kind of depends. All right, I'll do one more question I saw right back there. Yeah, so medications for LDL. Typically, like I said, statins first line. Once you're on statin, that's good. They can go higher doses of statins to greater impact that. There's basically 3 categories of statins. There's high intensity statins that reduce your LDL by about 50%. There's moderate intensity that are 30 to 50%, and there's low intensity that are less than 30%. So usually what we do is, maybe titrate the dose up as you tolerate it. Make sure that you don't have side effects. If that's not working, should have been first line actually should have been diet. I kind of overstepped that. Diet should be the first thing that you watch for. Reduce your saturated fats, eat good, healthy tree nuts are really good. Also, fish is good. Fish oil can help a little bit, probably not as much with LDL. It can help with your HDL, but getting that ratio up, more in favor of HDL, the good cholesterol, that's a good thing. And fish oil can also reduce triglycerides a little bit. Niacin is one that used to be used a lot to help with LDL, and really, if you're on a statin, you probably should stop taking your niacin today, and that is kind of a blanket statement. So just about anyone that's on niacin and a statin shouldn't be on niacin anymore. You guys probably saw that in the news recently, and basically that's an increased risk for side effects, the muscular side effects of the statins. That can cause a problem. Also, niacin can be a risk factor independently for infection and also for diabetes. It can make diabetes numbers worse, or can even cause you to progress into diabetes. So niacin's not a real safe drug anymore. Usually we focus on the statins, and that's statins, diet, and lifestyle modifications is the way to go. Got to get back to